At the outset, I would really like to thank Dr. Shailaja ma'am, the Ophthalmological Society of West Bengal, and also the AIOC for giving this opportunity over here. Very briefly, I'll be speaking more on genetics and genetic counseling and the utility of the testing. So if we are looking at it, then when we do genetic counseling, it starts with, it can be just an awareness. We want to, there's a certain condition in the family. We are trying to communicate that there can be a genetic background to this. There can be an inherited background to that. Discussing the options they might have, and then assisting the families to take decisions, as that can be retrospective decision or it can be prospective decisions. Now, when we are counseling, obviously we are taking care of psychological aspects, the consequences, the yield of the genetic testings, if we need to notify other relatives, or if there is a recurrence risk, if there is an age-related issue, or it's just a susceptibility or penetrance thing. So there are a lot of things that come in when we are counseling. The counseling is divided into pre-test and post-test. Pre-test would rather involve about the testing and why the necessity, and post-test would be our actionable points, and if there are more referrals that may be needed, and further consequences. So basically, counseling would be divided into assessment phase, diagnostic phase, analysis phase, communication phase, and then referral and support. So as you can see, if I just give you this, that we are seeing two children with truncal obesity, post-axial polydactyly, we see hypogonadism, we see acanthosis, and we see that they have RP. So can I ask, like, what are we looking at? We are probably looking at Bardet-Biedl syndrome, right? But now, just that see here, eye is one part of the entire syndrome. So this child, if we know, if you're just looking at RP, then it needs to be managed for other conditions. We don't even know whether this child would need. And if the sister, the elder brother would have known, then probably the younger sister would have been diagnosed at birth. So very simple things. So there are many genes. Now itself, Bardet-Biedl syndrome can have so many different genes, there are different types. So there are many genes and many diseases. So, and not everything would be genetic. So to assess this, that whether there is a genetic etiology or not, and whether there is a necessity to do the testing and there is an actionability or not, initially the counseling would deal with the yield of the test. And then what panels are we going to test? Because if we look at it, like increasingly as we grow, like in the previous slide as you are seeing, that number of genes identified from like 80s to now has increased significantly, and we are getting new phenotypes, new genes, and hence the need for testing becomes very important. And there are very overlapping genes. Like if you see over here, you can see night blindness, retinitis pigmentosa, just cone rod dystrophies, the LCS, so everything is overlap. So it might present as something, and somebody said in one seminar that, genetics has made us be more humble, because what we are thinking might not be that case. It might be something else that is coming up, and that is very important for the testing. Now here there's a 7-year-old child, and this child is with sensory neuronal hearing loss and optic atrophy. Now if we just look at these three, see it's a consanguineous family. If we just look at these three, what are we thinking of? Alport syndrome. So that is exactly what we thought. But here see, there's a small catch. We got a gene homozygous for Alport syndrome, but see, we got another gene which is for optic atrophy. Alport does not cause optic atrophy. Alport will cause some other eye manifestations, right? So here, if we would have just said that the optic atrophy is due to Alport and just test Alport specific genes, we would have missed the second gene, and probably the care to the child would not have been complete. So this is why, this is how here, in this case, the family has helped. Now this was a consanguineous family. So here comes the role of inheritance. So if we know what kind of inheritance is there, we can also help the family plan their future directives. Now this is another case where we show that this is a known case of Usher syndrome. They want to have a family. Now just doing a testing, so here retinitis pigmentosa and hearing and imbalance, so we are saying it's Usher syndrome. My genetic testing yields a variant which is related to Usher syndrome, but is this it? Unfortunately, if we just leave it here, we will not be able to answer the question that we are asking. Because you can see here 2 mutations are there, but I still don't know the inheritance. This is autosomal recessive, so 2 mutations has to be in trans, which means it has to come from either of the parents, while if it comes from just one parent, it will not cause a disease. So if we know it is the other side, it's in cis, then we are actually missing another variant, and we need to look at further genetic testing. So hence here, if we don't counsel the parents, it will be a problem. Now in this case, say here there is another gene which is related to retinitis pigmentosa, and hence carrier screening also becomes important in the woman. We can offer tests like amniocentesis, PGT, and we can also offer donors and test the donors and go ahead with that. Also, we have a panel of testing. So we have karyotype, we have MLPA, we have the panel of genes. Depending on what we look, we will offer those kind of testings to the patient. Now here there's another study where this is an established family which has retinitis pigmentosa. In this case, the brother is known, the other sister is known. We wanted to find out whether this sister had it or not. Understand, here I highlighted the word deletion. If I just do a genome sequencing in this case, I would miss if I don't do an MLPA. So choice of test over here becomes very important. Now, as you can see, these genes have a spectrum, and this spectrum is extremely important for us to understand what test we should offer, what is the yield of the test, and what test we should offer, and whether we are missing something. Coming back to the first case I showed, this is a Bardet-Biedl syndrome. If I do just exome and leave it over there, I would be missing this contiguous deletion. So as a geneticist, it's my duty to understand and take and counsel the patient for cascade testing. So hence one test might not fit all, and hence the counseling is necessary. Also, if I'm getting a homozygous contiguous deletion, I need to know the exact position so that I can give them a prenatal counseling which is necessary. Yeah, just take 2 more minutes. So this is a family where you see this person has an anterior segment disorder, and he has 2 mutations in PXDN gene, and we tested the parents. They are also in the PXDN, but this is a variant of uncertain significance. Now if you're looking at a variant of uncertain significance, ACMG has given us 28 standard criteria. Now if we are looking at something and here my segregation has matched, then I can go back to reclassify these variants depending on these 28 criteria. Because of shortage of time, I'm sorry, I'm just running. We could reclassify the other variant, but we couldn't reclassify the one. But then again, one likely pathogenic and one VOUS entails us for a prenatal testing, and we can help the family if needed. Now, so what we need to do is assessments in the sense of deep phenotyping, family history, genetic history, clinical interpretation, and then comes the clinical use of it. So we are doing it for diagnosis, inheritance, predictions, and also for the care that we are giving, and right now the potential therapeutic options. So it's a multidisciplinary team which will have clinicians, the labs, the patient advocacy groups, and also other referring clinicians which might be needed for us to say. So it can be prospective or retrospective. And there are a number of clinical trials that have come up. It has opened. There are more than 30 ocular disease trials which are going up. And in this case, the psychological aspect of counseling becomes extremely important. So while we counsel, we involve the patient in the decision. It might not be an optimum testing for them, but it should be a testing which the family is comfortable with. The idea is to reduce the patients which are historical, detect them early, and treat them. Thank you.